We'll start now with the GSK Symposium about the PRIMA trial, niraparib wow in advanced ovarian cancer, with Professor Emad Shash, Professor of Medical Oncology, NCI. I think everyone in the hall knows him so much, and he doesn't need any introduction. So Professor Emad, all the floor is yours.
Thank you, Dr. Bessel, for the nice introduction. It's really an honor to be here, and thanks for Bessel for making it happen to have all our friends from the MEMAGO and from other countries to be part of the 7th GO and the 7th MEMAGO. So I'd like to express also my thanks for GSK for giving me the opportunity to share with you some of my insights about the GSK Symposium. And actually, we have been listening yesterday and today as well to the era of the PARP inhibitors. So this will be the fact of my talk, and I guess that also it will be completed by the next session for my colleagues to dig more into the added value of the PARP inhibitors. So this is my disclosures, and what I was going to discuss today, and this is my agenda, is like to have a brief introduction about the epithelial ovarian cancer, having as well the ovarian cancer management principles towards the precision medicine, the PARP inhibitors as an example, then to expand more about the data about the niraparib, and to give a little bit of my insights about the healthcare disparities and how it can affect patient care. So then finally, take-home message. So we have been listening over the 2 days about the advances in gynecological malignancy and specifically in ovarian cancer. And actually, pre the era of the PARP inhibitors, what the maximum of the median progression-free survival is to reach us with the addition of the BEV is around 10 to 18%. And actually, 70% of women will relapse within the 3 years of the first-line treatment. And actually, we have a dismal overall survival of 38% of women with stage 3 and 4 to have the 5-year survival reaching it. So there is a significant unmet need for this, and that's why that digging into more of what we can bring. And listening to this, one of the main take-home messages is actually to treat patients with a high volume in institutes that is being capable of performing good surgeries and have a good MDTs to be able to give the patient the maximum care. So if you follow the patient's lifetime long activity, that then they will have the primary treatment, whether this is a primary debulking surgery followed by chemotherapy, and then having at a point there will be increasing of the symptoms once more, recurrence symptoms, PFS, and shortening over time. And ultimately, this will result into a disparity and have the fatality at the end. That what we know that the disease recurrence leads to the decrease in the patient-reported physical and emotional well-being. So it's not only affecting the survival, but the end of life care is also something that have an impact on the patient and their caregiver. So if we take an example of the DNA damage response pathway, we have definitely one of the mechanisms that happen is the single strand breaks. And this is being as well with the base excision repair mechanism, but also the double strand is another way where the DNA have the damage to have also the homologous recombination repair is the part which is responsible for the repair, and as well the bulky ducts that is being repaired by having the nucleotide excision repair and the translesion tenses. But as well, there is the nucleotide mutation substitutions, deletion insertions. And this is being having the effect of the mismatch repair to be the main mechanism for the repair. Talking about the PARP inhibitors, that what we know that the normal cell, and if you look into the left side of the graph, when there is a damage by the single strand, the presence of the PARP enzyme that will result in to be fixed by the base excision repair. But also, if there is a deficiency in the PARP, but there is an intact BRCA1 and 2, then there will be a fixation by what we call the homologous repair. And that's actually basis that when patients have a BRCA mutation and will undergo, and when the PARP is being inhibited, then there will be a cell arrest of the tumor. So approximately half of the high-grade serous ovarian cancers are harboring the defect in the homologous recombination. And if you dissect this, you will see that 13% will have the germline BRCA mutation, 22% in total will have both the somatic and the germline or somatic only, but as well, when you go up, the HRD and having this approximately the 50%. So it makes the good sense that we are moving from one size fits all to having more depth of the understanding of the biology underneath. And that's the HR repair genes may have mutations, deletions, amplifications, or protein methylations. And that's actually, the BRCA will be sensitive to the PARP inhibition as what we have mentioned, and what we know as well that the HRD may be sensitive to the PARP inhibition, and this is the hypothesis. But then there is a new era where also we have understood from biological understanding and preclinical data that some of those who are HRD negative may be sensitive to PARP inhibition. And only a small portion of patients may be not sensitive to PARP inhibition. So we are talking about the PARP. What the PARP have done, it's actually that proved the efficacy in the recurrent disease. And we have 4 main pillar trials, the Study 19, the SOLO 2, the NOVA, and the ARIER, where either the olaparib or the niraparib or the rucaparib to be involved in changing the aspect of those who are recurrent disease. Those, or majority of them, except of the SOLO 2, was for all comers, and that's the basis that possibly that it is working not only for those who have a BRCA, but also for those who are non-BRCA patients. So moving forward in the first line, what we know that it's challenging to treat despite the good response to chemotherapy or the addition of the antivascular endothelial cross factor. What we go into have the debulking surgery, the chemotherapy, then to wait, and this is the way we are used to treat our patients. But the fact when you introduce the maintenance is actually to have the prolongation benefit following the surgery and improving the survival through the progression-free survival, and hopefully this will have an impact on the overall survival. And what will make it work, that the maintenance, when there is a maintenance of the quality of life of patients. So by this into the context, there is a change in the treatment paradigm that we are introducing more and more the activity. The first of them is to actually have the olaparib and to be followed by the others starting from the year 2019 with the olaparib plus the bev or the niraparib and as well the rucaparib later on. So let's dig more into details about the PARP efficacy in the first line setting. And first of them is the SOLO 1, which is the maintenance olaparib in the BRCA mutated newly diagnosed ovarian cancer. And simply it was a randomized double-blind phase 3 study that included patients with newly diagnosed FIGO stage 3 and 4, high-grade serous or endometrial, but with BRCA mutation to be randomized either to olaparib or placebo after having a CR or a PR for the platinum-based therapy. And clearly what was seen that the PFS beyond the end of treatment is continuing. So it's not only the primary endpoint, but it's with the maturation of the data. And recently, last year at the ESMO, there was the data about the overall survival, and what we can see that with the hazard ratio of 0.55, there is a gain in terms of the survival. So that means that we are making a progress there. With the 44.3% of patients in the placebo group as well received subsequent treatment with PARP inhibitor. So despite this, there is still an observation of overall survival gain. And the question was to combine with the anti-VEGF, and that was answered by the Paula treatment. It's a different slide of the population, but to have it with a newly diagnosed ovarian cancer that underwent PR or CR, or after upfront interval surgery, and to have addition of at least 3 or more BEV cycles, and to continue with the BEV as a maintenance for 15 months, or the olaparib and the BEV, the olaparib for the 2 years and the BEV for the 15 months. So what was observed that again for the PFS by investigator that was the primary endpoint, there was a gain in terms of combining the olaparib and the BEV. And what we have seen as well, that it's expanded from the BRCA to the HRD. So actually that was seen as well for this trial to have the progression-free survival into the HRD positive, including the total BRCA mutation, but as well those patients who are HRD positive but not BRCA mutant. But what we knew that the HRD negative is not working to give the olaparib plus the Bev. And actually, what we have seen in the non-BRCA is to have the PFS by the clinical risk. So that was observed as well. That was concluded by the data about the overall survival to be consistent that patients who are BRCA mutant or patients who are HRD positive excluding BRCA mutation, there is a gain in survival. But HRD negative are not gaining this survival. Till coming the PRIMA, which is a maintenance niraparib versus the placebo in the ovarian cancer, those at a high risk recurrence after first-line platinum. And that was a trial that actually really simulated what we have in the real life. So these are patients with newly diagnosed ovarian cancer and with response to 6 to 9 cycles of chemotherapy. And as well here is a primary endpoint, which is the PFS in a hierarchical order. That means that to prove as well that it is effective in the HRD positive, then into the overall population, and having this equal secondary end of points like the overall survival, PFS to quality of life. What was enriching in this study as the baseline characteristics for the trial, to have 84% of patients had residual disease after the primary debulking surgery, 35% of patients had stage 4 disease, and 67% had received neoadjuvant chemotherapy. So those, what we know that they are of a high risk and as well having poorer prognosis than those who are not in this category. So what was shown that the PFS in the HRD positive was in the niraparib at 21.9, that is double what was seen with the placebo. And as well, the PFS in the overall population that was seen, that means that we went to the overall population to have it after being proved into the HRD positive patients. So that if you go into the subgroup analysis, you will see that there is a benefit in the all subgroup analysis. And as well, this was confirmed that later on with the PRIME, which is in a similar fashion, but it's actually to have a niraparib in a 200 milligram dose that based on the weight of the patients. And what was proving as well in the PRIME trial is to have the PFS by the blind independent radiological review in the primary endpoint, and as well to confirm that the activity of the niraparib is not related only to the BRCA mutant patient, but also not to the HRD, but its activity in expanding to those who are non-HRD patients. Then the last one of them is to have the Athena mono, which was also being presented in the ASCO last year with the maintenance rucaparib, to have the arm which is the arm B, which was for the rucaparib plus the placebo, versus the arm D, which is the placebo arm for these patients. And to confirm what was seen, that the median PFS assessed in the intent to treat population is being observed, and as well for the HRD population, and to have this as well confirmation of the rucaparib in the HRD negative population. So now we have 3 molecules together, or having them with the Bev, what to choose. And that's what is very important point to take in consideration, that to factors that informing the prioritization of the different PARP inhibitors. And I'm not seeking to cross-compare the trials, but it's very important to see the magnitude of benefit based on the risk categorization. So we all know that the high risk factors is the stage 4, to have a visible residual disease or no surgery, to have a neoadjuvant or no surgery, as well to have a partial response to chemotherapy. And if you look into the PRIMA trial, you will see that this is at the highest of the high risk population, with having stage 4 of the 35%, 47% in those who had a residual disease, 67% of the population underwent neoadjuvant chemotherapy, there was 31% who had partial response to chemotherapy, and BRCA wild type who are 70%. So definitely this is very one good example to see that those who are of a high risk, that you are performing for them. And actually, what you can see as well with the approved PARP inhibitors, the activity of the key adverse events, that to see and to be aware that what is there and what you are going to discuss with your patients is very important. But what you will be also able to prove that the quality of life is being maintained in all patients with PARP inhibitor to be taken, whether the solo or the prima or the paula. So providing the collaborative evidence-based equitable care is something that we extrapolate with the healthcare disparities. And the suboptimal treatment is usually associated with poorer survival that have been reported in older women, in patients who are low-income women, and women with public health insurance coverage or no insurance. And that patients with ovarian cancer who didn't receive the guideline recommended care have poor outcomes. And here it should be not only for medications, but for the optimal surgical management of those patients. So you can imagine that 56% with ovarian cancer will not be able to receive the guideline-based care. And that's a pity because this is affecting the survival. So how to improve the survival is actually to have a timely access to care. MDT is very important. You need to have patient navigators, community health educators, social support, then definitely cost reduction and access to clinical cares. So it's all about the collaborative care. So please treat your patients with ovarian cancers in MDT, treat all cancer patients with MDT, but this is the way forward. So my take-home message, that the frontline PARP inhibitors, that we now have 4 clinical trials with the different 3 molecules, either alone like the olaparib or the niraparib, or combined with the olaparib and the bev. And what we know that what you can go into these for newly diagnosed patients who underwent either primary surgery or went to have a complete response or partial response to platinum-based surgery, whether they are germline somatic BRCA mutant, HRD positive, or HRD negative, PARP inhibitor with niraparib is being there and is being able to change the progression-free survival. And with the updated mature data of the olaparib, we now have a survival data. So this is definitely a game changer in the treatment and the management of the first-line ovarian cancer. Thank you so much for your time and listening.
Thank you for your great presentation. It was excellent. I'm a medical oncologist also.
Thank you. I know that I'm not the only black sheep in the room. So.
Yeah, I think so. But my question is that we know that the PRIMA trial include the highest rate of poor prognostic people.
Yeah.
There are more stage 4, there are more neoadjuvant, there are more PR also, patients include that. But we have ICON 7 trials also include the high-risk patients with bevacizumab with better overall survival. So if you're in clinical practice, what do you think about the patient selection? Who will get bevacizumab or niraparib? There is no data so far. Maybe phase 2 data available and it's ongoing, but there's some confusing.
Yeah, indeed. I totally agree with you, and that's a very excellent part. Definitely, if you have a patient who already started on a BEV within the context of whether you give it in a new adjuvant or that was the decision of the MDT, and according to the availability, I would recommend to continue, if the patient HRD positive, is to continue on olaparib. But actually, and that's unfortunately that we see a lot of patients that are coming to our facility after doing inadequate surgery, so this is a part. And unfortunately, those patients may be HRD negative, So this is a way to prioritize for them niraparib if available for them. And thanks that now in Egypt we have being registered niraparib as well, so it's available in the market. So this is, we don't have the rucaparib till now. So what I will say that definitely this is a debatable point. You have it, there's a lot of things. Where you are treating your patient, if it is any institute, if there is a reimbursement for the medication, but definitely now availability for those who are HRD negative, you have data about the niraparib to give it, so this is no question. The debate will be in the other 50%, which is patients who are BRCA mutant. We have a lot of mature data about the olaparib with overall survival data. So this is also adds into this. But what you can see from the separation of the curves of the niraparib, it's a class effect. So this is what we observe. And still there is needed of maturation. There is the other trials of the niraparib plus the BEV, which we are expecting to have some results for it. So this is also the way, whether there is a needed value of the BEV or not, this is also what we will learn, because this is a very important trial, and that was highlighted yesterday in the highlights for the trials that we are expecting in the future. So again, what I will give as a take-home message, please don't treat patients alone as oncosurgeons or gyna surgeons. Please put it in the MDT, because this is the question that we need to answer.
Yeah, I totally agree with you, but I believe that we have to reserve bevacizumab for the further, almost 40 or 50% of patients still recurred, even they got PARP inhibitors. Even solo one, we see 40% of patients recurred after the 5 years. So we need to opportunity to give better treatments. We have Aurelia trials, combination with chemotherapy plus bevacizumab. So I believe we have to just conservative to use that kind of together, all together.
And I do agree as well, that will be another question, what to do if a patient received PARP in first line, what shall you do when there is a recurrence of disease? So this is also something, an open question, and I guess that we are learning every time with what shall we do for such patients.
Last question.
Yeah, sure.
Do you use Caillem score for?
Excuse me?
Caillem score? Caillem for CA to 125 decreasing score that use French group.
I'm not a fan of this, but it's type of follow-up. So the CA 125 as a tumor marker is shouldn't be the base for this. However, this is a part of the risk criteria for those who are stage 4 with ascites and CA 125 to have it as a risk category. However, to base decisions based on this is again a debatable point. You don't definitely, if patient is not receiving any treatment, then definitely we have an answer that the CA 125 is not the way to initiate new treatment. It's only if you have a radiological evidence of recurrence. So this is what we know. For the risk categorization, yes, definitely this can be in a part of risk categorization, which we have the data from the GOG for those patients who were high tumor markers and having ascites to be benefiting from the BEV more. So yes, that's a way to have it. Again, it's a work in progress, and we have more and more data to come. But what I'm a believer is actually to have deeper genomic analysis for our patients, because this is the better way forward for them. Depending as well on the availability, the reimbursement, all the kinds of this. And I agree with Professor Said with the financial toxicity. All this is being on cost effective. I was not there, but in the beginning of the presentation of the last session, but with the conclusion, I guess we are always going into cost effectiveness with medications. However, I will argue that there is a cost effectiveness if you go to a good center and oncosurgeon at the beginning as well, because this is, you can go to non-trained gynecologists who will do a suboptimal surgery, this is not cost effective. So cost effectiveness only is not only with medication, but also with the whole process of the treatment and the management of patients.
Okay, thank you. Excellent.
Thank you.